So good morning. My name is Harindra Wijeysundera. I'm the CADTH Vice President of Medical Devices and Clinical Intervention. On behalf of the entire CADTH team, it's my pleasure to welcome all of you to the second plenary of the symposium, which is entitled Beyond Health Technology Assessment, What Does Health Technology Management Mean for Patients and the Health System? So I'll be your moderator for this session, and we've decided on a somewhat unique format. Health Technology Management, or HTM, is a term that is used increasingly frequent and represents an evolution in our approach to medical devices and clinical intervention through the life cycle, from early awareness of innovations or horizon scanning, to adoption, to the transition to standard of care through implementation, reassessment, and disinvestment. Given these newer concepts and terms that many people may not be familiar with, in the first half of this session, we will hear from three experts in the field to provide a framework for HTM from priority setting to HTA and HTR, and you will see many other acronyms that we will define by the end of this session, and how to operationalize implementation with quality standards. In the second half, we have stakeholders from a patient, industry, and clinician perspective who will provide their insights into both the promise, but also the potential concerns and obstacles to HTM. Now, given the weather in Ontario, unfortunately, two of our speakers were not able to fly out. But luckily, they'll be joining us by audio, and I sincerely appreciate their flexibility. I'm very glad that they can join us, despite Mother Nature not really cooperating. Now, we are live streaming this presentation, and so for those of you online, please send in questions anytime via your player. Now, finally, I will apologize in advance because I will give very brief introductions to each speaker and our stakeholder panel. And in no way do these introductions give justice to both the depth of their expertise and the impressive experience that they have in each of these areas. But in fairness, if I did, I'd use up almost all of our time. So I'd ask all of you, their bios are in the program, and I would advise and encourage all of you to read them. And so with that, it's my pleasure to introduce our first speaker, Dr. Craig Mitton, who is a professor in the School of Population and Public Health at UBC and the co-director of the Center for Clinical Epidemiology and Evaluation in Vancouver. And he will be speaking on priority setting in healthcare. How can HTM be operationalized? Craig?
Well, thanks, Harindra, and good morning, everyone. Thanks, Tammy and Peter and Brian, for the invitation. It's a real privilege to be here with you this morning. I love coming to Halifax. I've been here many times. It's a great city. Had the opportunity to travel around the Maritimes with my wife and kids a couple of years ago. We just loved it here. Lots of lobster tails and just lots of fun. Just great people, and so yeah, really, really grateful to be out here and have this opportunity to talk to you. So, just by way of disclosures, I'm not aware of any conflicts that I have. I do have a couple of relevant affiliations. I am a member on the Drug Benefit Council of BC, which is the formulary recommendation body in BC. And I'm also, as co-director of the Center for Clinical Epi, we do HTA work. We have contracts with folks like CADTH and the BC Ministry and our producer of health technology assessment. So what I wanted to do is talk about what I've spent much of the last 20 years grappling with and being challenged by, and that's the issue of priority setting and resource allocation in the health system. I'm a researcher, but I'm an applied health services researcher, and spent a lot of time working with health authorities, governments, hospitals. I've had the privilege of working with about 50 public sector organizations over the last 20 years, doing the types of methods that I'm about to talk about on the back of a research program and work in the field. So this to me is really meant to be, sure, you know, I've got a research background, but it's really meant to try and be about how to implement and how we can move this idea of health technology management forward. I should note that from my perspective, a priority setting framework really has two elements, one being a value assessment activity, and two being a choice-making mechanism. And we'll come back to that in a couple minutes. I think Deputy Minister Abbott yesterday in the plenary talked about priority setting and defined priority setting in much the same way as I have on this slide here. And so for me, it's thinking about the value assessment and the choice making, and how do we do that in practice. I'll come back to priority setting in a sec, just by way of definition and make sure we're on the same page. And I know Fiona's going to go into this in a little more detail with respect to definitions. But I think we all know what HTA is. I think CADTH has done a particularly good job of taking a broader lens and has been true to form with respect to what HTA actually is meant to be. Many people have, over the last number of years, defaulted into a focus in HTA work around just clinical and cost effectiveness. And frankly, that's not good enough. It doesn't speak to the broader set of factors that decision makers are faced with. And then by necessity, we see some of that irrelevance coming out with respect to HTA. And I'm really pleased to say and can applaud CADTH for their important work in taking that broader lens, that the original intent and some of the factors are listed there on the slide. HTM really then refers to the management of health technologies, goes beyond the focus of new and into the focus of existing activity throughout the life cycle. And I think it does start to move HTA into a realm where it can have more relevance. In a paper, a recent paper in Health Economics that we put out, led by Sterling Bryan, we talked about this idea of technology management, and the title of this paper, if you can see it on the screen, is Breaking the Addiction to Technology Adoption. And we put it out there because we were seeing an analytic emphasis on the new. And we were trying to challenge those who do HTA work to think, in fact, about that life cycle, about existing technologies. And in my view, what we really need to do is move away from that adoption idea, which is really the 1 or 2 or 5% activity in the system, and get our heads around that 95, 99% of the activity, where we can have greater analytic emphasis across the whole spectrum of services. And the reason I say that is, for the deputy ministers that were on the stage yesterday, for the many of you who are healthcare decision makers, whether it's in government or health authorities or LHINs or hospitals, I think this is what you grapple with all the time, and you struggle, from my experience in working with many executive teams, the decision makers struggle with that one-off HTA in a silo. And what we need to be thinking about is how to manage resources overall. That's what healthcare decision makers are grappling with all the time, but yet HTA doesn't really give the answer to that broader resource management issue. And frankly, I'm not sure it was ever meant to do that. It's if you think about an HTA lens, it's more focused on operational efficiency, trying to figure out how best to provide a given service, not thinking about whether we should be funding or to what extent we should be funding. And those are questions of allocative efficiency, which a broader framework is required for. And so I think we do need to move away from this idea of these one-offs, these HTAs that come in and try in a siloed way to assess value into a place where we can have relative value assessment. And as my colleague Stuart Peacock likes to say, get into that notion of what's the value proposition. And we can only do that when we start to think about opportunity cost with a broader lens. So in my view, HTM can actually be operationalized in the manner where we're talking about priority setting and resource allocation. And this slide just represents a few thoughts in terms of what we need when we're talking about priority setting. We need a framework that can be informed by economic evaluation for sure, but also recognizes the many, many other types of evidence. And it wasn't lost on me at all yesterday with the 2 sessions on real-world evidence, how decision makers have a very different view of what evidence is than your average health economist or health services researcher. And I think more researchers need to understand the constraints and challenges that decision makers face, and indeed broaden their own understanding of what evidence can be brought to bear. The framework obviously needs to be pragmatic in that it needs to deal with decision-making in a constrained time, resource-constrained, and evidence-constrained environment. And we need to be thinking about, yes, investment, but reassessment and reallocation on an ongoing basis to get at that notion of the value proposition before us. Stakeholder engagement in some provinces is built into legislation around priority setting. In other provinces, it's just needing to be there for good practice. And in that, obviously, the host of stakeholders that we need to be thinking about in terms of clinicians, patients, the public, et cetera. And so I think HTM can actually be performed quite efficiently through a priority setting approach. And this framework that has come out of our work over the last number of years. There's lots of references I can point you to on this framework. Peacock et al. 2006 BMJ, Gibson and myself in Journal of Health Services Research and Policy in 2006. More recent stuff we've written around the methods for assessing change and that value assessment. But in essence, what this rather simple diagram allows any decision-making body to do is to say, okay, what's the aim and scope of the decision activity? Have an advisory panel which is multidisciplinary, look at your existing spend, where resources are going currently, and then get at, on the back of a robust set of decision criteria, what options for change might be put forward. Options for both investment and options for disinvestment. And in that, coming up with recommendations to move, shift, reallocate resources to better move an organization towards the objectives that are stated. Where does HTA fit in? Well, HTA is the key input, a key input with respect to evidence generation. As I said a few minutes ago, I think we need to get out of that idea of HTA being this siloed, one-off, do we do it or do we don't, and moving it within the thinking of a broader resource allocation framework where it's seen as an input into a broader approach to get at that relative value assessment, the opportunity costs, and allowing us to think about that in a much more explicit and transparent way. The people on this diagram are just where there's many opportunities for public engagement. I myself tend to think that patient engagement belongs and it can be done appropriately within the HT activity, and I think some of the CADTH optimal use activity that's going on there is really leading in terms of thinking through how patients can be engaged in an HTA. The public can be thought about with respect to what the criteria should be, where the decisions should be made, and how that impacts a broader set of stakeholders with respect to investment and disinvestment. So in summary, HTA focus on new technologies, I think has really limited itself in terms of its relevance. HTM makes HTA more relevant, and I do think that having a mindset around HTM belonging within a broader priority setting frameworks that we have, which are well tried, true, have been used many, many times over, can move this agenda forward. So I'll end it there. Thank you.
So thank you very much, Craig. So our second speaker is Dr. Fiona Clement, who's an associate professor at the Cummings School of Medicine and director of the Health Technology Assessment Unit at the University of Calgary. And she will be speaking to us on using a health technology management lens to reduce low-value care.
Thank you. Sorry, I'm just getting my water sorted out here without spilling anything. There we go. Good morning, and thank you also for the invitation to speak to you today. So I'm going to just open by defining my acronyms and how I'm going to be using them in my presentation. So the way I'm thinking about health technology management, really if you were to think about a spectrum with technology adoption being perhaps the beginning of the cycle and technology de-adoption towards the end, HTA would of course come before health technology reassessment, or the reassessment of things that we already do in the system and have an established pattern of use. And I really think about health technology management as encompassing both of those concepts. So really driving us to look at new technologies that we're considering adopting, as well as technologies that are already in use. To think about that along the technology diffusion scale, we might put health technology management even broader across this technology development scale. So on the far, my left, you would have development of a technology, early integration into a system, a formal decision to adopt, moving into stable use, possibly overuse, and then eventually a managed exit of the technology as it becomes obsolescent and replaced with something newer and better, hopefully. So those later stages are really where we're talking about reassessment and where we can drive forward the agenda around low-value care. So when I talk about low-value care, what I really mean is technologies or care practices or drugs that are not providing us optimal value. So they're either limited or perhaps no clinical benefit to the patient, or perhaps they're not cost-effective within our system and we should be doing something else. So why is low-value care a problem? Well, first off, it's possibly harmful to patients. So in that situation where a technology provides no clinical benefit, why are we putting patients through that? We should expect, and I hope we all have, the opportunity to have high-quality, evidence-based care, which is kind of the antithesis of low-value care. Within our scarce healthcare resource dollars, we do want to be spending it on things that achieve maximum value. And so again, putting us into a dichotomy of high-value care where we simply can't afford to have low-value care. And then lastly, if we want to have space to bring in new technologies within a budget where we've already allocated every dollar we have to activities, if we can find and eliminate some of that low-value care, we should have room in our budget to be thinking about integrating new technologies. How big is this problem? So CADTH did some work earlier this year, and they put out a report estimating that approximately 30% of spending in care in Canada is low value. And we see very similar estimates coming out across the globe in other healthcare systems that have estimated this. In the States, it probably won't surprise you to know the number is higher, but 30% is where we're at. So over the last 5 years or so, we've really been in a startup phase to address low-value care. And I'm very excited to say that many of the key steps that we needed in this journey happened right here at different versions of the CADTH conference. So thank you for all of the support along the way. And now I'm very excited to see as we move towards implementing our learnings into a complex healthcare system, trying to actually do this and solve the problem of low-value care within our system, CADTH is again taking the lead with their HTM strategy. So our conceptual model for HTR really is 3 phases, 2 steps within each phase. So first we have to figure out what we're going to target. So identification and prioritization being the 2 first steps required, and people are already tackling that for us. So Craig has talked about a framework that he's been using. There are other initiatives like the Choosing Wisely campaign that we could use that are identifying and targeting and bringing to the forefront low-value care practices. Next, we need to make a decision. And this is where HTA would fit, or the tools of evidence synthesis. And then that would be fed into a policy development process where the outcome would be some kind of a recommendation. The third and crucial phase, where I feel that we need the most work and we often fail fast, is the policy action phase. So here we really need somebody to do something within the system. So we need implementation, and then we need ongoing monitoring and evaluation to see if what we did actually worked and achieved what we hoped it would achieve, and didn't achieve things that we really didn't intend it to achieve. You notice along the sides there's 2 foundational pieces, the first being meaningful stakeholder engagement, and the second being ongoing knowledge exchange and utilization. Both of these are crucial. They go top to bottom in this phase, and you need solid stakeholder engagement for this to be successful. So what are we seeing emerge internationally? We're seeing kind of 4 buckets of activity coming out in this space. So the first is HTA+, which is where HTR would fit. So as Craig's already outlined, traditional tools of HTA are not fit for purpose. They're one piece of what's required in the low-value care journey. And so we're seeing this utilization of HTA as the base and really expanding into that implementation space. We're seeing a growth of knowledge and some attempts within a KT and implementation framework really being driven out of the implementation science world. We're seeing some list-making activity, and then of course some fabulous priority setting work, PBMA grounded activities coming out of Vancouver with Craig's leadership. So to think of two examples, we would put health technology reassessment within the HTA Plus box, and a very familiar list-making activity to many in the room might be the Choosing Wisely Canada activity, where they put together lists of low-value care and share that widely with their stakeholder groups. So as we move forward within this, there are many tensions emerging within a complex healthcare system. So just 4 kind of dichotomies that have emerged in the literature around the challenges that we might experience when we're moving forward in a system. The first being this tension between strategic thinking, and HTR will require, and HTM will require a strategic focus of an organization, and balancing that with the firefighting, immediate successes, pressure at the moment to really decrease the budget and make changes, and balancing those 2 requirements. The next is a tension between what people would describe perhaps as practice-based research versus academic-based research. So people like myself in the academic-based research really struggling to find common ground with people who are in the coalface in the system saying, we're doing this, and perhaps there you might see some quality improvement initiatives. And so balancing how are we moving this forward and recognizing that both of those worlds have a role to play here. The other emerging tension we're hearing a lot about is discrepancies between the areas of the system that have resources to move this kind of agenda forward and those that don't. So there are areas of the system where if you talk to them about launching something around reassessment and low-value care, they echo back to you, I'm firefighting every single day in my healthcare system dealing with patient needs in front of me. Thank you for pointing out that there's low-value care. We don't have the resources to deal with that while I'm firefighting. Versus other areas that might have some extra resources where they can advance this. And then the last really strong tension that's emerging in the literature is incentivizing people to come forward and do something about their low-value care, recognizing that it's their resources and their efforts and their behavior that may have to change. What is the incentive for them to do that when they're busy all day kind of fighting fires and taking care of patients in front of them? Versus maximizing the value in the system, which is really the lens that low-value care and reassessment take, is how can we maximize value across the system, yet individually when we're silo budgeted as we are, why would people be stepping forward and saying, well, I can free up some resources that better the system? So there's this tension emerging there. So what do I see as the major barriers for HTR moving forward? The first is that there needs to be engagement across multiple levels of the healthcare system. So using our Alberta language, there needs to be leadership at the ministry level for Alberta Health. There needs to be political support for some of these decisions that will be quite charged. And that support and prioritization and recognition that this activity has to happen needs to funnel all the way down through the different layers of leadership within the system to people who are at the front line making individual patient care decisions. That is an alignment that is, I think, very hard to achieve and will require a lot of effort and stakeholder engagement. Next is, of course, the difficulty in identifying and prioritizing low-value care. What are the right things to be going after here, and how do we move that forward? And then the last point is very little guidance and very limited methods for the implementation piece, and I know Terri will speak about that in a moment. So my final reflections on moving this forward, and what it's going to take is collaborative partnerships. And so again, I'm very excited to see CADTH stepping up the plate to be a leader here and bringing people together to get some momentum going across the country with some very, very key partnerships. There is going to be accountability questions. So who is going to move this forward and who is taking ownership for the success of this across the country? And the last piece is crisis. So I do think that right now we're in a fiscal crisis, and that is really propelling this conversation forward and propelling the need for things like an HTM strategy, a focus on low-value care. And this crisis, this is going to sound callous, but I think if it lasts for a little bit longer, we're going to get enough momentum that we're going to be unstoppable. I think we're all at a point where we can recognize that we spend a lot on our healthcare system, and the growth that we've experienced within that budget is no longer sustainable. And so this is no longer an optional program development, but a requirement. Thank you.
So thank you very much, Fiona. So now we're going to have Terri Irwin, who's going to join us by phone. She's the Director of Quality Standards at Health Quality Ontario, HQO. Terri, are you on the line?
I am. Can you hear me?
Yes, we can. I don't know if you are live streaming this, but just to give you a sense of the scene here, we're in a large room that is packed with very interested individuals. There's no freezing rain in Halifax. It is drizzling a little bit. And so with that, you'll be speaking to us on HTA and quality standards. Do the right thing, just do it, but do it right. Thank you again for joining us by phone.
Thank you so much, Harindra, and I'm sorry I can't be there in person. Huge thanks to CADTH for inviting me to be part of this panel. As Harindra mentioned, I'd like to spend a few minutes talking about how I think quality improvement methods and implementation science can be considered as part of HTM and used to support the uptake and adoption of health technology recommendations. I'll also walk you through an example of how Health Quality Ontario has leveraged these methods to improve care for Ontarians living with a diagnosis of major depression. But first, just a quick primer, if you can change the slide, on the role of Health Quality Ontario. So HQO is an agency of the provincial government with a mandate that's set out in the Excellent Care for All Act. This mandate is threefold: to develop evidence to support decisions, to measure and report on the quality of the healthcare system, and to support quality improvement based on all of this. To me, HQO's mandate is much like the power to conduct ongoing PDSA cycles across the province to effect improvement in many areas of care. Next slide, please. One of the most powerful parts of this mandate is a combination of health technology assessment, quality standards, and quality improvement. The relationship between health technology assessment and quality improvement, I think, is described well in this paper by Paul Glassue and colleagues from 2011 that was shared with me by my colleague and boss, Irfan Dalla. This is a great paper that describes the different philosophies of evidence-based medicine and quality improvement, but also describes how they can work together as an impactful duo to affect change in healthcare. Next slide. When I read this article, I took away three messages. Do the right things that are effective and provide value for money. Do them, but don't just do them right. Next slide, please. At HQO, we help people do the right things through a mandate to develop evidence to inform better decisions. Next slide, please. This evidence development function is made up of two programs. First, the Quality Standards Program, which is a program that sets out to develop a library of standards that consist of concise sets of strong statements that focus on conditions or topics where we know there are large variations in how care is delivered or where there are gaps between the care provided and the care patients should receive based on the best evidence. We develop these in collaboration with a topic-specific advisory group of patients, physicians, other clinicians, caregivers, to achieve four main aims: to help patients know what to ask for in their care and to have discussions with their care providers, to help health professionals offer the highest quality care based on the best evidence, to help healthcare organizations and professionals measure, reflect on their practice and improve the quality of care, and then finally for health system planners to make decisions to create the environment for healthcare professionals and organizations to deliver quality care. The second part of our evidence development function is our health technology assessment program, which is a team of clinical epidemiologists and health economists led by my colleague Nancy Sickett, who's in the room with you today. This team evaluates the evidence for different technologies for clinical effectiveness and value for money to make recommendations through the Ontario Health Technology Advisory Committee to the Ontario Minister of Health regarding public funding of health services. These two functions work together in a powerful combination: quality standards to highlight gaps within the system and HTA to help close those gaps through funding recommendations. Next slide, please. Our work related to major depression is a great example of this. In 2016, we released a quality standard for the care of adults and adolescents with a diagnosis of major depression. In this standard, we made a statement that patients with a diagnosis of major depression should be offered 16 to 20 sessions of psychotherapy. The advisory committee for this standard had a really hard time making this statement because they knew that this is virtually inaccessible within the current system. Psychotherapy is currently only publicly funded if provided by a physician, and there are not enough physicians to satisfy the demand of patients needing psychotherapy, so the wait lists are very long. So unless a patient has the means to pay for psychotherapy, they are left on these long waiting lists, a huge inequity in our system. Knowing this and knowing that there are many highly skilled non-physician clinicians, nurses, social workers, psychotherapists who provide psychotherapy, our HTA team then conducted a health technology assessment to determine the clinical effectiveness and value for money for structured psychotherapy provided by non-physicians. In 2017, the Ontario Health Technology Advisory Committee made a recommendation to the Minister of Health for public funding of structured psychotherapy provided by non-physicians to increase access for patients with a diagnosis of major depression, and in this case, generalized anxiety disorder as well. The Ministry is now hard at work planning for the implementation of this recommendation across the province. Next slide, please. Quality standards in HTA are not just about doing the right thing. We knew early on in developing the Quality Standards Program that we needed to put a lot of effort into supporting the implementation and adoption of the standards, or else they would just end up sitting on a shelf or on a website. Next slide, please. So in addition to providing guidance on doing the right thing, we also provide recommendations on how to do it. Each quality standard is accompanied by a set of recommendations to support adoption of the standard within the system. These recommendations are made at different levels. We make recommendations to partners within the system to develop clinical tools to support the standards. We make recommendations to ourselves to leverage HQO programs to support adoption. And finally, and most importantly, we make recommendations to the Ministry of Health regarding policy changes that can be made to support the use of the quality standard. Here, related to major depression, you can see a recommendation for adoption to the Ministry of Health to use the OTAC recommendation to implement the provincial structured psychotherapy program for people with major depression. Next slide, please. This recommendation is then taken by the Ministry, who in the case of psychotherapy made a strong commitment to the implementation of publicly funded structured psychotherapy for Ontarians living with major depression and generalized anxiety disorder. As I mentioned, work is well underway to plan out the implementation of this announcement. Next slide, please. Finally, in addition to providing guidance on how to do the right things, HQO strongly believes in using implementation science to support the system to do the right things right. Next slide, please. This book by Tricia Greenhalgh explains that doing the right things right is a complex matrix of multimodal approaches to support improvement. She explains that there is no one-stop shop when it comes to implementing evidence-based healthcare, but that a multitude of approaches that are bucketed under headings like people, groups and teams, organizations, citizens, patients, technology, policy, networks, and systems are necessary to achieve the admirable goal of evidence-based healthcare. Next slide, please. It became very apparent to me after reading Greenhalgh's book that HQO is doing a pretty good job at supporting this multimodal approach to the implementation of evidence-based healthcare. First, we develop the evidence through standards in HTA, and then we link this evidence to quality improvement initiatives. For example, through my practice reports, which you can see on the top left of the slide, we provide data to clinicians about their own care. Every family physician in Ontario can sign up to receive a customized report that provides them with data on how their practice compares with that of their peers. We also work with organizations to help them develop quality improvement plans. More than 1,000 hospitals, long-term care homes, primary care organizations, and home and community care organizations now submit a quality improvement plan to us each year. We also support quality improvement networks and collaboratives. We have about 60 hospitals enrolled in Ontario's Surgical Quality Improvement Network, and together they're working to improve surgical care across the province. We have an online community called Forum that's dedicated to improving the quality of healthcare across Ontario by allowing people to connect with others working in healthcare quality, identifying opportunities to collaborate, stay informed, receive support, and share what works and doesn't work. We help to build capacity for quality improvement together with the University of Toronto and the Institute for Clinical Evaluative Sciences. We have trained more than 2,000 healthcare professionals in Ontario in a common language and approach to quality improvement through our IDEAS program. We work with academics so that proven interventions can be spread across the province. For example, through the Arctic program we delivered in partnership with CAHO, we are helping to spread rapid access addiction clinics across the province. Finally, we report on the quality of healthcare. At the provincial level, we hope that these reports help shape policy, and at the local or regional level, we hope that these reports help decision makers allocate resources and decide where to focus their attention. Next slide, please. As I close, I'd like to talk about patients. As a nurse, this is one of my favorite topics. As I mentioned, Green Hall also talks in one of her final chapters about patients. The patient voice, she argues, is all too often missing from initiatives to improve the quality and safety of clinical services. She goes on to say that patients are central, not marginal, to the implementation of evidence-based healthcare. At H2O, we've taken this advice to heart. Whether it be determining the H2O strategic direction on our board of directors, submitting topics for quality standards and HTA based on their experience, a source of evidence for our health technology assessments and quality standards, patients play a valuable role in everything we do at HQO, because as our CEO, Joshua Tepper, would say, a high-quality healthcare system cannot exist without the active and meaningful participation of patients and the public. Thank you so much, and I look forward to continuing this conversation.
Thank you very much, Terri.
Perfect. Wow, that was impressive. So thank you, Terri. That was great. A lot of information, and I must say, as somebody who's beginning the journey from a lot of experience in HTA to HTM, I'm faced with the ambition of what we're trying to do, but also the fact that there is a lot of learnings that we can get from across this country, lots of deep thought that has been put into this and experiences. So we're going to switch gears now and go to our stakeholder panel, and it's my pleasure to introduce them. We have three members, Dr. Maureen Allen, Brian Huskins, and YJO. So YJ is going to be joining us by phone, and she's the Managing Director of Edwards Lifesciences and brings a 2-decade experience in the medical device area and also pharmaceutical sectors. And she's also on the board of directors of Medic. Maureen is a family physician who practices in rural Nova Scotia and has been a health professional for over 3 decades, beginning her career as a nurse. Her clinical interests are continuing education, end-of-life care, and building community capacity to manage substance abuse disorders. And finally, Brian Huskins is an established community leader in patient engagement in the voluntary healthcare sector. He also has over 30-year experience working with community-based social and health organizations and has served on many advisory committees as a patient representative, both at the local, provincial, and national levels. And I've had the pleasure of serving with him on these, and he's a passionate and valued voice from the patient perspective with lived experience of chronic illness. So I'll start with you, Brian. There's a lot that you've heard, a lot to take in. So perhaps you can start with your perspectives from the patient standpoint and also any questions that you may have for our three experts.
Okay, thank you, Harindra. Yeah, my mic is on. I have to sort of switch between glasses. It's another thing that happens when you're almost 60, right? I guess my observation, and this is an observation that I'll throw out, just a general observation to people who are here as well as, not so much targeted at the panel, is that I've heard a lot of comments about it's great that individuals, it's great to have patients in the room. We really value patients. We like patients. We need the role of patients. The participation is important. And I have no doubt that the individuals who say that truly, truly in their heart mean it. My challenge is that I think that you couldn't say anything else in this room and get away with it. So whether it's the politically correct thing to say or not, and people say it because you couldn't say anything else in this room or else we'd all attack you. So I would challenge people to think of it because I think it's more of a systemic issue. It's not necessarily the people in this room or the people who actually value it. It's your peers and your counterparts when you do leave this room, I think, are the bigger challenge. It's not the clinicians that are in this room, it's maybe the person that I see, depending on my, what specialist I need to see. So I would just sort of throw that out as a general comment, is that we hear lots of good things about patients when we're at conferences like this, but I know that the experience of patients and my peers, they're very different when we go outside of this room and back into our various communities across the country. So, I don't, that's not an attack on anybody, but what I would do is I would challenge each and every one of you in the room to become one of our allies in terms of educating those people that you work with, to truly integrate that into the way they operate. So that's sort of a general statement. There's a few things that sort of struck me, and I'll deal with yours first, Dr. Mitton, and I looked at your PSRA diagram, where the first step was to define aims and scope, and then the second step was to form an advisory panel. And there's a part of me that when I think of a presentation that I did yesterday on essential medicines, that there's maybe, I would challenge a little bit of that paradigm, because I think that you should form the advisory group first, which should include patients, because defining the aims and the scope of any project or any initiative, if you define it ahead of time and then walk into the room and say, now we're going to do a committee, I think that there's a wrong order to that. And I think that's an issue that from a patient perspective that I would have to raise. I know that that's sort of a standardized historical paradigm, and we all live with the histories that we bring into the room. So I would just throw that out, and that's just a think about it thing, because when I talk to my peers and when we identify issues, most of the issues start with what is the question we want answered, and we're not necessarily a part of that. And I think that we end up refining the question sometimes as we go into it further because we haven't been involved up front. So that would be sort of just one thing I would just throw out in terms of that you would actually form your group, and then even if it's a smaller group that will expand, I would just sort of throw that out there as an idea. Dr. Clement, there's this whole piece of, you have the health technology assessment and the health technologies reassessment, but there's this big, huge gap in between, right? And I don't know whether I know from all the things I've read what happens in between, and I think we have to start defining that stuff, because certainly from a patient perspective, we're involved in the assessment. I assume we will be involved in the reassessment, but how are we involved in between? How do you collect the data that says this is no longer something that should be part of a system? Where do patients fit into that? Where do clinicians fit into that? So I think that, I know that this is just a panel and you can only do so much, and some of the sessions probably touch on that, but I just throw it out as something that I always wonder, what is that piece in between? Because that's where we will usually get left behind. And so I throw it out there. The other one is, and I agree, health technology assessments, others bring them forward to us. One of the challenges, I think, in this area is that we have a market-driven process. The manufacturer or the supplier brings forward their technology, which puts us in the position of sort of sitting back and waiting. And I know that it's difficult, but I would like to sort of throw into some of that scenario of how do we actually put out front a more proactive approach to it, because the market-driven, Canada, let's say, doesn't have enough of a market, so we're not going to introduce that product. So what happens then is you get something that is so devolved and so spread in another country, like in the US, let's say, south of the border, that when it comes here, we almost have to do it. And, even with the bad data sometimes that we get, just because of the pressure and that sort of pressure on it. So I throw that out there. I think that when we talk about the tensions, there was one that sort of was missing for me, and it fits for everybody, and that's some of the who. because there was the other tensions, time, effectiveness, resources, and money, but there's really a human sort of tension in there as well. And again, from a patient perspective, we're trying to put into very clinical and very non-judgmental systems a human element, so it's always a challenge. And it's easy for me to throw out the challenges, and I understand that. And all of this is just highlighting some of the things that when I get it and I get a little butterfly in my belly, because it's not going to cause a problem tomorrow, but it's going to cause a problem a year and a half down the road. So just sort of that who piece, I think we avoid it because it's the messy stuff. We're not the Canadian Association of Social Workers. We don't deal well with the human element necessarily. So to pull some of that into it. And then probably the last one for Terri from Health Quality Ontario, which came up to me, was when I'm not talking in a Health Quality Ontario volunteer perspective on this one. When I looked at all the tools you had, very few of those tools were directed at patients. For instance, my practice, you have one that is directed at physicians. A lot of the information generated is useful for patients, and so why can't patients sign up? Because it's all computerized. There's ways of doing this. I know I can throw this out because I don't have to balance the budget. But when I look at that, there's no patient piece on it, and it would be really nice to see an organization like Health Quality Ontario, and it could expand to CADTH, where you have some of that patient input and feedback or something. I do it through LinkedIn, where people who have a specific specialty I have on my LinkedIn, and they flag something and I'll read it. That sort of a thing, because then I don't have to read everything about community development. And I'll just wrap up by saying, that one and decision aids, I think there's a gap in there, and it would be interesting whether as a sort of a system of people across the country, everybody who's involved in this, somehow start putting the question, what information are we generating that patients want to see? It's not about the decisions that are made, but it's about some of the other information that's collected. So there's not necessarily questions specific, but those are just some observations.
So thank you very much for that, Brian. I think there will be some themes that will emerge from each of the stakeholders from their perspectives. And so perhaps I'll wait till the end to have the experts comment, or we can discuss at that point. So now we'll go to the phone. YJ, are you with us online?
I am, Harindra. Thank you.
So hopefully you've been able to hear all that's been discussed. Your perspectives from the standpoint of industry, of this transition from HTA, which industry is very familiar with and has been involved in that process, to this broader HTM policy.
So thank you, and thank you very much to CADTH for involving MEDIC as the Medical Device Industry Association for Canada to participate. And it was very interesting hearing the expert panel's assessment of HTA and how that leads to HTM. And one of the things I would say that's unique about the medical device industry, which differs from the pharmaceutical, which I think CADTH is quite well versed with, is that from a medical technology standpoint, we are truly a part of the whole healthcare delivery system. And a lot of times, the efficacy of the devices, whether it's an acute care setting that goes all the way to home care, really relies on the skills and the experience of the physician, the quality of the hospital, and many other factors, which are contrary to how pharmaceuticals work. And so one of the things that I would say when we look at an industry of medical device association that we are in Canada is that we definitely work in partnership with physicians to take the feedback from patients and how are they working. And a lot of the times, because of the iterative nature of medical devices, we don't have as much evidence to come through when initially the innovation is available. And a lot of times that is created in real world situations. And so I would say that's probably one of the biggest differences of how devices is viewed for assessments when we look at the paradigms. And so one of the things I would say from an industry standpoint is ensuring that when you do an assessment of a medical device technology, that it has an appropriate, HTA or HTM model to value it, because it is a very different technology than how pharmaceuticals is looked at. So much of what I'm going to talk about comes from two papers. One is the Joint Healthcare Industry paper, and it's the title is called "The Value of Industry Involvement in HCA, produced in 2011, and most recently, it is a paper put together by Medic with Optimus, and it's a paper that came out last year, and it's quite apropos, I would say, with regards to the discussion today, and it's called The Innovation Dilemma: Achieving Value, Health Outcomes, and Contributing to the New Economy. So I would say, on behalf of industry, I think what was really pleasing to hear from all the speakers is that we have a common goal. And so when I look at the things that industry is looking at, I think first and foremost, we are very much about enhancing quality and safety of patient care. And I think, as I mentioned earlier, from an industry standpoint, a lot of our technologies cross the full spectrum of patient care. And so we want to make sure that the patient's quality of life is factored into a lot of these decisions. You know, our technologies are very much in the acute care setting, and it helps and enables the patient to come home sooner, and also helps remote monitoring with some of the devices that are actually created and designed here in Canada. I think the second point that I want to bring up about the industry is that our goal is to improve access to truly have effective medical technologies across the full continuum of care. And a lot of times these are done in partnership with various different stakeholders. The third point is that from an industry standpoint, we are very much supporting, and I think the other speakers talked about the constrained fiscal condition of our publicly funded healthcare system. And what I think was very positive, and I'll reference Dr. Mitton, what I think from an industry standpoint we're on the same page about is not just looking at an isolated relative or an isolated HTA in a siloed environment, but looking at the relative value of a technology across the broader framework of care for the patient. And I think that's probably one that we are all very much aligned with, but hard to try to operationalize. And the fourth point that I'll make is, from an industry standpoint, we truly want to help with the economic development through investment and highly skilled jobs in Canada that can relate back to the HCA and HTM and the quality networks, that we want to be an active part of how we can bring a lot of these innovations to life. And I'll reference the MEDIC conference last week. We had a section on innovation, and we had the Federal Minister of Innovation, Science and Economic Development, Minister Baines, as well as Bill Ternesky, who I believe spoke yesterday, and Justin Reimer, the ADM for Science Innovation for Alberta, all talk about the importance of industry in helping with innovation in Canada and helping bring more patient-centric focused innovations to life. So, you know, when we talk a little bit about where industry contributes, what I would say are there's a couple of 5 main points I think industry can really play a part with how we can help with HTM and HCA for Canada. And so when I look at the 5 parts, what we would say is, you know, we know that there's a fragmented and silo-based healthcare system. I think industry has a very unique part because we touch all the different areas within the healthcare system and can see what each, I think, function within that delivery system is dealing with or struggling with. And so we want to be a part of the discussion when there's discussion about HTM, how we should operationalize, I think, a lot of these technologies. I know that there were other stakeholders that were discussed, which includes obviously first and foremost, you know, patients as well as the healthcare providers along the system. But from an industry standpoint, I think we do play a valuable part in helping, you know, piece together some of the information across a fragmented system. You know, the other issue that I would say that is apparent is really around the focus on short-term savings for the system. And again, it was discussed by the speakers that we really need to be focusing on the total cost of care and the long-term savings and overall value that a lot of times the innovations that industry brings can impact for the total system versus the current siloed way of distributing care. You know, what's interesting is that, you know, I'll call this out, but there is sometimes a lack of trust between the public and private sectors. You know, I feel that the role that industry can play is to help continue to build collaborative and a transparent working relationship that helps, you know, take that negative perception that may exist in certain areas and really make it a very transparent and very positive collaborative effort. When we talk about, for example, quality improvement, a lot of times when you look at parallel industries, quality improvement comes specifically from the manufacturer. So I will use Toyota as an example. They're heralded as being, as they say, the Kaizen approach, continuous improvement. And they look at their manufacturing process and they take in feedback from not just employees, but also the end users on how to improve efficiencies within their manufacturing system. And I think this is probably value that industry can play a part, is our lessons learned in other markets, our lessons learned in why we have manufactured or created the innovations that we have to help really shorten the time frame with regards to bringing some of these innovations to life and operationalize within the healthcare system. And then the final point that I would say is probably a big issue is risk aversion. So I think just natural change in how we currently do things leads to, some risk aversion on how to bring a lot of these new innovations. And so, I think this plays a bigger part in how do we look at shared risk management through different models? Because currently right now, I think the contracting process to bring innovation to life or to operationalize it is very restricted in the current process. And I think it's fair to say that industry is open to looking at different ways of risk sharing through shared data generation, through looking at outcomes. And I think it'd be very fair to say that industry wants to be a part of that and to be able to help contribute to the overall success of a healthcare system like Canada. So I would say in conclusion, what's positive is I think there's an appetite to look at the value of innovation across the system. I think it's, the challenge is obviously our current model, which is where it's siloed. I think, we talk about wanting to be collaborative. I would say that industry is very much wanting to be a part of that and wanting to share the information that we have from our innovations and how it can benefit and where we feel that we can be a partner in helping put the patient at the center of how we have these discussions, and which is ultimately what we're here for. I think the one part that we'd also want to talk about from an industry standpoint is that we want to make sure that the process is transparent and that there is open decision making and it provides opportunities for participation and consulting with industry where appropriate. We certainly want to be a part of the solution. We want to make sure that our innovations can be given and brought to Canadians across the country. And we just want to be a part of how we can realize a different way of bringing these innovations to life and help shape the different models that we need to have in place in order to do so. So on that note, I will transition back to you, Harindra.
Thank you very much, YJ. So Maureen, you are truly at the coalface of care delivery. So what are your thoughts on what you've heard?
I just want to thank CADTH for actually having me here. I'm a totally newbie to this in the language, so bear with me. So primarily my practice is a rural-based or very remote-based practice. And I will tell you, especially going through this exercise with the Nova Scotia Health Authority and how we're reorganizing healthcare provincially, is that most of us at the rural community, which is about 40% of our population actually in Nova Scotia, are completely out of the loop in terms of the decision making. So a lot of the technology and the implementation of technology is actually done from the top up. And it usually is introduced into our communities, and then we have to adopt these technologies. So it creates a lot of frustration, even though that technology or that that particular guideline or that approach may actually be something that can improve care. And one of the things that I've learned, and I'll give you an example, something like, so I'm an emerge doc, actually. I don't do family medicine. I wouldn't have the patients. Family medicines are incredibly important in terms of our healthcare system. But if you look at something like the Canadian Triage and Acuity Scale, is based on times, is that we introduced this technology, but we haven't allowed our health practitioners and nurses in particular to see how that technology might be better, especially if your wait times are not huge. And that was one of the hardest things for our community to implement, is that wait times to be seen in the emergency room were actually very low. And so they were penalized because they weren't using the system. So now we're at a point, though obviously the waits are incredibly long. But it still doesn't allow flexibility for our nurses. You have to input all of these guidelines and all of these processes that need to be assessed around guidelines. So when I look at falls assessment, when I look at suicide assessment, so all of that takes time, and in the end what happens is they get penalized because the flow through isn't as fast as it should be. So there are some challenges, and the other thing that I think is so important when technology, or when we're implementing some of the technologies, is that we allow communities to find a way to let go of systems or processes that they themselves have been using that have been probably very efficient, but this new process may be even more efficient. It's almost like they have to mourn the loss of that technology that they've been using, so they have to go through that and be able to vent their frustration, even though you're still going to move them forward with the new technology. And there's been a lot of things that have been said, and I'm just kind of going through some of my notes. As most of you know, healthcare professionals are very resistant to change. Even if change is something that's going to improve the care for patients. But one of the most powerful tools that I have found, especially in a rural community, is the movement around choosing wisely. So we can use evidence that is universal to bring about change within our communities around guidelines. Most of the changes that we implement in our communities are around quality initiatives. So emergency rooms are incredibly valuable areas. If you ever want to know, we often refer to them as the canaries of healthcare. They really give you a sense of what's happening in your communities, what resources are lacking, what things need to change. And so many of the initiatives that we do in our community actually come from the frequent users that we see in our emergency rooms. So implementing quality initiatives by looking at our frequent users, connecting them to the care that we have, which may be very limited, can make a huge difference. So we can actually provide feedback, obviously, to individuals that are sort of top-up individuals that are bringing some policies or some guidelines or even some technology into our communities. And I'm not sure if that's the same experience that most of my colleagues, but it's been very frustrating. We have always been problem solvers and solution finders within our community, and we've completely lost that with the restructuring. So most of us are trying to find our way back forward. I do see some light. We're in our third year of transition. But there is a strong sense of the loss of autonomy, and I think it feeds back into our patient care as well, because if the clinicians and the healthcare providers are feeling that loss of ability to impact care at the local level, I'm sure our patients are feeling the same way, especially when they try and access resources. So, when we try to make these sorts of changes, it's important to understand, the impact that they have on the levels of care that are being provided with people on boots on the ground. So it's just a few of my thoughts. Yeah.
Thank you. Thank you to all three of you. Those were, very thought-provoking comments. And if there's a central theme through all three stakeholders, it's the sense of true integration of their perspectives, more than simply asking for advice after decisions have been made or halfway through the process. So I'll focus our experts to address that, how the movement to HTM and these frameworks that have been presented plans, or how best that they can integrate patients, physicians, and industry. And I'll start with you, Terri, specifically with quality standards and the tools. Brian mentioned that predominantly his perception of them is that they have been directed to physicians, to care providers as opposed to patients. And perhaps you can comment on that. Is there a move towards tools that are directed towards care receivers and patients?
Yes, so thanks so much for directing this question to me, because I was dying to respond when I was hearing Brian's comments. So we do have quite a few resources that we're developing internally at HQO, and then also partnering with others to develop tools to support the standard as well. So with each quality standard, we have a plain language version of the standard that's available to people, patients, and the public to understand what to ask for and to have informed conversations with their care providers. And through the process of developing these, we've learned along the way. So we've recently started doing a process called emotional journey mapping that kind of addresses your comment, Brian, about how we engage patients at the beginning to determine the priorities. So we felt like we were engaging patients too late in our process when we first started. So now we're engaging patients at the very beginning of the development of the quality standard to understand their healthcare journey related to their condition, to help us to determine the priorities for improvement within the system that then guides the statements that we make within the standard based on the evidence. So we have the patient reference guide. We also are working with partners to develop shared decision-making tools. So you saw in my slide the decision aids. Those are really meant to be used together, the patient with the care provider, so that both parties are singing from the same songbook. And then more tools as we engage more with patients around quality standards, to understand what patients are looking for. So we started to include checklists as part of our patient reference guide, a place for patients to record their notes. So we're learning from patients along the way about how to improve these products as we go along.
Thanks very much, Terri. So Craig and Fiona, perhaps I'll ask you, both of you have thought about these frameworks a lot. So there are many people who need to be at the table, multiple levels of ministries, regional health authorities. So how does one fully integrate patients, care providers, clinicians, and industry, three groups that no one would argue are central to the process? How do you integrate them in such a way that meaningful contributions can be made? Yeah, please.
Great, thanks, Harindra. And thanks, Brian and Maureen and YJ, super comments. So when I think about a priority setting resource allocation framework, which would appropriately have HTA as an input or component with respect to the decision-making process around value assessment, to me, that priority setting resource allocation framework has to have a multidisciplinary advisory panel. And that panel, and I really take your point, Brian, about when's that panel formed and how early is that engagement occurring. Often when I get a phone call from a CEO, that's the start of the conversation. We've got a budget deficit, or, you know what, we know that there's better ways to manage our resources. Can you come alongside of our executive team and work with us? So usually that first call doesn't come from a patient, but a proactive organization will very quickly form that advisory panel that includes key clinicians who are champions, who are willing to engage, as well as members of the public. And I've been involved in countless examples where we've engaged both clinicians who, frankly, were disengaged and not feeling on side with management and decision-making, and members of the public who have come alongside and said, and to the point where sometimes decision-makers don't always listen to each other at these tables, whereas you have an engaged public member at the table, everyone puts down their devices and looks them in the eye and says, wow, we really need to pay attention here. So we've done some really, really cool work around implementation of priority setting where we've had public and clinicians at the table alongside of the managers. So it's exciting. In terms of the industry, I think the points that YJ is making, fantastic. Obviously, we're on the same page around relative value. I think more so including industry in terms of the HTA activity itself with respect to mechanisms to collect real-world data, understanding risk sharing, bringing in that industry evidence that they can bring to bear and willing to participate through that aspect of a priority setting resource allocation cycle. So for me, Harindra, all three of these players absolutely are central and fit well within a priority setting model. So,
Fiona?
I wanted to go back to the word that you used, and also I think one of the words in many
models or frameworks that is just glossed over and it's meaningful. And I think we throw about this idea of stakeholder engagement without focusing on that authenticity and what is meaningful. And to me, I think that starts with, first of all, asking the stakeholders what is meaningful to them. And the answer will differ. But I think there also has to be an authentic question. I'm actually coming to you and saying, what is meaningful engagement to you within this context? And Brian, I really, your point around, we say we want patients at the table because there's no other palatable answer. I think that's a very shrewd observation. And I think that in some ways, when we're coming to anybody and saying, well, what does meaningful engagement look like? There are different levels, and people will want to be engaged differently. Different groups will want to be engaged differently. And honestly responding to that in an authentic way if we're bothering to ask the question in the first place. And so to me, it really comes back to relationships, trust, and authenticity in all our engagements.
Thank you. So I'm sure people have a lot of questions, and I'm conscious that we're running out of time. So there is a break after this, so I'd encourage any of you who have questions for the expert panel and the stakeholders to please come up afterwards. I do have one question which has been directed to me, which is a fairly fundamental question, so I feel I should answer it. And the question is, what does HTM mean to CADTH, as this is our symposium? And I feel in many ways, for the last 45 minutes, of the last 75 minutes, you've had the answer to that, which, as somebody who's still relatively new to CADTH, I've been here for 8 months, and part of the transition to HTM, it is really one of, to me at least, somebody who's in my previous life studied HTA as an academic endeavor. It's one of humility, that it is an ambitious task which requires us to take a step back, speak to stakeholders, patients, clinicians, I'm biased as I am a clinician, and industry, and recognize that we don't know the path forward, and take that advice of how to move forward, learn from what's been done in other jurisdictions, advice and thoughts that our academic colleagues have done, to find a path from moving simply to adoption to really influencing, having an active management of the entire life cycle. So rather than the passive role that HTA plays. So with that, I thank all of you for your attention, and we'll close this session.